Shall we begin? Maybe. 1 second. Continue.
You want to move it?
Yeah, sounds good. Okay, thank you. So we do not have any disclosures or conflicts of interest to report. And, you know, over the years, aggressive therapy and intervention was considered medically necessary and appropriate for the treatment and prevention of certain infectious diseases, especially in the newborn and pediatric population. Our changing environment and always new data that's being supplied to us means that we as scientists or we as clinicians need to be able to adapt and change and be able to really analyze critically information to be able to make changes if it is worthy and not be afraid to abandon old thoughts or old methodologies. So the big question kind of has been coming up now, which is, are we over-treating our population, causing more harm than good? So today's Journal Club, I hope to engage everyone in some interesting thoughts, as well as hopefully stimulate some conversation at the end that might find several groups, depending on different demographics, leaning one way towards leaning a different way, a young school versus a more traditional train of thought. So the objectives for today is that we need to practice formulating a question, and then we're going to use that PICO method to try to come up with a question that we want to then try to answer. We're going to appraise articles and help understand the uses and limitations of retrospective cohort studies with the help of the CAT formats for cohort studies, or the clinical analytical therapy. And then we're going to discuss and contextualize concepts. You know, retrospective studies, we'll briefly go over means, medians, and standard deviations to make sure that everyone is prepared to fully digest quickly the information that we'll present to you at the end. And then we're going to use internal validity of cohort studies, and we're going to pick important factors there. And then we need to determine the external validity of our article and see, hey, is this applicable in our clinical settings? So for Journal Club, you know, it's important, and we need to come up with a question. So that's kind of a big theme with why we do these journal clubs. So how do you kind of come up with a question? We like to use the PICO TT format. So, and me and Matt working together, our question we decided to come up with was, what do we want to do? All right, so we want to look at a population that is greater than or equal to 35 weeks of gestation born to mothers with a diagnosis of chorioamnionitis. We wanted to see some exposures of these children. So the exposure was chorio, and then we wanted to compare. So those that were immediately treated with empirical antibiotics versus those that were not, or maybe took a more observational approach. And then we needed to measure some outcomes to see what we can formulate here to help our question. So we thought, okay, let's look at sepsis, death, mortality, readmission rates of the different groups, clinically significant and objective labs and vitals. So now that we've kind of formulated our question using this information, what type of question is it? So theoretically, it's a therapeutic question. We want to see the therapeutical analysis of this, but therapeutical questions, to get the best answer to your question, you really need to use randomized controlled trial studies. So there were none for the question that we wanted to ask. So what was the next best option? Prognosis-style question formats. So for prognosis-style questions, the top of the pinnacle of the triangle, the most optimal is systematic reviews. Our search didn't really find any there either. But as you go down the pyramid, which you'll see in just a second, cohort is the next best available to give us good evidence to answer our question. And as you can see here, at the very top is your systematic reviews. These are the strongest evidence that can help you answer your questions that you're seeking, followed by randomized controlled trials, our cohort study, which we have, case controls, and then down at expert opinion, but I'm sure the expert opinion makers are different about this one. So, in our search, we found our article that was going to best help answer our question. Chorioamnionitis and the management of asymptomatic infants, 35 weeks, without empirical antibiotics by Drs. Jan, Ramanathan, and this one's tricky for me, Kayabab. It also just happened to be the first ever article I received from Pediatrics as my intern year started. It was in July 2017, volume 140. So what do we want to know? So what is some really relevant stuff that's kind of going on right now? So the current guidelines that were established in 2007 by the CDC and AAP recommend empirical treatments to all infants who are exposed to chorea, symptomatic or not. But, however, you know, there are some institutions that are bucking this trend. And one institution or society is the Canadian government. So as you can see here, Canada was more of an individualized investigation and treat each patient individually. And at minimum, they closely observe. But if the baby is ever symptomatic, they're not going to withhold treatment, but you're going to immediately start treating. Are they group B positive? Still, it's all kind of coming down to an individualized approach for at least 24 hours, taking vitals, taking important labs, and closely monitoring, and then treatment is initiated if it's deemed clinically relevant. So I thought that was quite interesting that there's a whole government organization. Back in 2003, the Society of Canadian Pediatric Society was in coordination kind of with the CDC and American Academy of Pediatrics here, where they had the same guidelines that we now have. But in 2015, the Society of Pediatrics of Canada, the College of Family Medicine, the Society of OBGYN, and the Child Task Force for Pediatrics, Infectious Diseases, and Immunization all approved this and is now in use. So what is something that's more relevant to us here as colleagues of Chorioamnionitis? Well, Chorioamnionitis, we use the current guidelines set out by the CDC and AAP. If you're diagnosed with a chorio or a mother's temperature is 100.4, we are going to immediately initiate an early onset sepsis screen, and we're going to immediately start empirical antibiotics with AMP and GIN, and then we're going to draw cultures. The good thing that we do here, which will differ from our study in our article, is that the baby, if it remains asymptomatic, still gets to be with the mother, still gets to promote healthy breastfeeding and mother-infant bonding, which is good. I want to thank Dr. Hayes, which I saw earlier, who I started getting tunnel vision, I guess, for help with me and getting some of this information, always being willing to answer questions when needed. So thank you, Dr. Hayes. So something else that I found interesting about kind of what we do here. So risk factors for early onset sepsis could be group B positive strep mothers, could be chorioamnionitis. But we have different protocols for group B positive. So if they have signs of neonatal sepsis, straight to antibiotic therapy. But if you're born with group B positive mother, even if she has proper IAP or intrapartum antibiotic prophylactic, greater than or less than 4 hours, or greater than less than 37 weeks, or even a ruptured membrane longer than 18 hours. We're still observing 48 hours in field symptomatic. So with Grid B strep here in our hospital, we do more of a observation, while chorio, we are doing straight up treatment and not withholding. So the medical problem, are we too aggressive in our immediate empirical treatment of newborns? Sorry to people online.
I thought it was just gastric. More television than you thought.
Yeah.
That was great.
So are we too aggressive in our immediate treatment? You know, it's just something that we need to formulate. And the study objective was to evaluate the outcomes of asymptomatic chorioamnionitis exposed neonates without the immediate empirical treatment. So the article that we had used a methodology where they chose a retrospective cohort study. They went back in time to the dates of May 2008 to December 2014, and they did a paper chart review. And they pulled all the charts of infants and mothers from the hospitals of LA Children's and Southern California, LA neonatal departments. And the infants and mothers that were included, the chart had to have a diagnosis of chorioamnionitis, and the mother had to receive intravenous antibiotic treatment accordingly. Infants were included if they were initially asymptomatic and transferred to the newborn nursery. And infants were excluded if they were immediately transferred to the NICU or had records. Now, how did we get to the mother's diagnosis of chorio? It had to be the presence of a fever plus uterine tenderness, pleural amniotic fluids or discharge, leukocytosis in the mother, and maternal tachycardia. So it was fever plus one of the five below. Then the data collectors and the investigators started going through all these charts that they pulled of that population, and they said, okay, mothers, let's record all the data about maternal age, race, mode of delivery, duration of ruptured membrane, Tmax, GBS status, and the use of intrapartum antibiotics. Newborns, what were they looking for? So gestational age, birth weight, the APGAR score. Important lab values of these newborns were of relevance to this study was the CBC with DIF, high sensitivity CRP, blood cultures, CSF analysis, and then if present, it was also reported for the sake of the investigators with placental pathology reports and neonatal clinical outcomes were also jotted down. So when our investigators, as we talk about this journal, they needed to find a hospital that kind of didn't have our policies here brilliant, but had some maybe more of the older policies before 2007. So LA Children's and Southern Cal, they had these kind of policies in place. So any infant 35 weeks or greater, asymptomatic, who was exposed, they were observed with usual care. They were kept in the newborn nursery, but serial laboratory data was obtained, and empirical antibiotics were not administered. If they had any signs or symptoms of sepsis, they were immediately booked over to the NICU, and antibiotics were started. Lumbar punctures were performed for clinical sepsis, positive blood culture, or persistent abnormal lab values. All right, so with these asymptomatic infants that we're now collecting our data on, so we had initial blood culture, CBCs, and high sensitivity CRP. These were drawn from birth to 6 hours as a repeat draw at 12 to 24, and then a third draw from 24 to 48. Normal values for us were 5,000 to 30,000 white blood cell count, band counts less than 10, and a CRP of less than 10% or 10 micrograms per liter, a different value than we use here because ours would have been 1. Abnormal values, if these appeared at any time in those 3 initial draws, then they were immediately transferred to the NICU, don't forget, and antibiotic therapy was initiated. So the abnormal values that we were looking for, the observers were looking for, was greater than or equal to 1 of the following white blood cell counts greater than 30,000 or less than 5,000, band counts 24% or higher, CRP greater than 10, and or positive blood cultures immediately sent them to the NICU. Unfortunately, as one of the downfalls of a retrospective study, you can't always find what you're looking for. Immature neutrophil to total neutrophil ratios was not used because at the hospital at the time, they weren't doing that. So before we really get into looking at the data of what they want to present, for some of you, this is a quick review. Retrospective cohort study. I'm standing here. I want to start to observe population set. I look backwards in time. I'm looking for an exposure. And I'm looking for an outcome, and I want to compare those two. Does one associate to the other? And I want to compare the incidence. It's similar in only one aspect to a prospective study. They both start at the same spot. You either turn backwards or you go forward into time. Prospective studies, you go forward, and you're able to follow up with patients, something that you can't do in the retrospective studies. These are quite nice if you own a low budget. If you're short on time, they could show some benefit because when you do a retrospective study, some bias is eliminated because since you're looking backwards in time, say the institution, the provider, the caregivers, the teams there, they don't know that you're kind of watching them. So that bias is eliminated. Unfortunately, there's a different type of bias that then comes in, which is the confirmation bias that, say, I'm the investigator, I'm looking at the charts, I could put my own bias in to pull charts or pull data that subconsciously or what have you, I now inject bias. So that was just quickly about the retrospective study that was done, our methodology. Odds ratios, as we remember, we want to associate the difference between exposure and the outcome. We use our 2x2 table, disease, yes, no, exposure, yes, no, inversely relate, and do some arithmetic, bada boom, bada bang. OR ratios of 1, there's no association between the outcome and the exposure. If it's greater than 1, you're that many times more likely to be associated with that particular thing. And if it's less than 1, it's also less likely that that exposure will present with that outcome. So mean, median, standard deviations, we should all be quite familiar with this. The mean, which we'll be using in some of our data before, the set of all, the sum of all of the set of numbers divided by the number of elements. Median is the middle in that set, and then the typical Gaussian bell curve, Gaussian. How do you pronounce it? Gaussian. Thank you. Gaussian. And as we know, our values there. So when we were talking about the data that we collected, maternal age, temperature, all that stuff, those are now categories that become variables in our study. So the best way to look at variables here is we use the chi-squared, or x squared, and we want to reject the null. We want to nullify the hypothesis of negativity here, or the opposite of what we're doing. If it is on the chi-square curve, then the null hypothesis is true. It can reject any scientist or clinician's proposed thought. so we want to be on the opposite side of that one. And for our study, the significance of ours was set at P is less than 0.05. So as Matt's presenting some of these numbers, that's the number we're going to look for to say, hey, was there any significance found in the numbers that we're presenting? So that's kind of a little background on what this article was about, how we came up with our question, the importance of understanding how to read and interpret and to analyze the data. And then Matt is going to present the data from this article and the results, or not the data, the results of this article. So here you go, Matt. Take it away. Is that good? Does that work?
All right. I like the Bob Barker microphone that Alex has for Grand Round for this. Okay, so let's go through the results of what was actually found out of the article. During the study period at the two institutions, there were about a little over 5,000 total live births that were under gestational age, of which 364 of those infants were exposed to a mom with chorioamnionitis. 122 goes straight to the NICU, and then the 242 is the actual study group that we're really investigating. Of the ones that went straight right out to the NICU, 95% of them went for respiratory distress. The sort of sticking point, though, is that we don't have full data on all of those NICU admissions. Only 45% of them had a documented reason for going to the NICU. So is there some other reason that the kids are going to the NICU? Hard to say. But for the ones we do know why they went to the NICU, respiratory distress was by and large the reason that they had gone. And then this is the primary study group that was investigated in the article. Again, 35 weeks gestation or more, labs collected, CDC with diff, with goals of normal labs being defined as white cell counts between 5 and 30,000, bands less than 10%, CRP less than 10. I think Dr. Scott, Dr. Keel had commented on, we use a different normal value for our CRP. Instead of milligrams per liter, we use milligrams per deciliter. So that's the, what was that? Oh, fancy. Thank you, sir.
That's covered.
Right, so here. And a blood culture is also done. And labs were taken at 0 to 6 hours. They were repeated 12 to 24, and then again at 24 to 48. So there are 3 lab value creations out of it. And then we use I to T ratio, but the machine that they used, I think, didn't create a total neutrophil count, which is why they didn't use the ratio. There was some institutional thing that they sort of commented on briefly. So out of all of the kids, choreo looked good. What happened to those kids, right? So about 2/3 of them stayed in the mother-baby unit, which is kind of nice, right? Didn't receive any antibiotics. 94% of them breastfed at least once. And they were able to go home after their cultures were no growth for 48 hours, barring some other reasons that mom had to stay or whatever, but at least the baby was able to go home after 48 hours of no growth on their cultures. And then there were no instances of readmission to the same institution for sepsis or any issue. Dr. Whalen, sir.
Sorry for the ignorant question. I'm not reading, but what drove the decision? What drove the study group into those two different?
As in who goes to NICU and
we're
who?
Just looking backwards. We didn't set a point or a decision that we're comparing. We're just looking backwards.
So why did they go to the NICU? Is that your question? Stay tuned. 2 slides.
That's fair.
3rd go to NICU. Here's why. So either they developed a symptom, a clinical symptom, or they remained asymptomatic but had an abnormality on their labs. So of those 76% of them, asymptomatic lab abnormality, 24% became symptomatic. So kids continues to look good, labs look bad. Why? CRP, 27%. CRP plus other stuff, 29%. This is very useful, Dr. Hart, thank you. Isolated leukocytosis, leukocytopenia, vandemia, 13%, and then a positive blood culture, 15%, 12 total. There's a note here, well, I'll get to that in a second about the blood cultures, but and then of the kids who developed a clinical symptom, then prompting them to go to the NICU. Respiratory distress, just like in the ones who went straight to NICU, was the most common so 9 out of 19 is about 50% of those who developed a symptom. Poor feeding, hypotonia, hypoglycemia, temperature instability were common things. And then the blood culture results. So of the kids who went to NICU, the bulk of them did not have any evidence of bacteremia on like finality of blood cultures. There were 15 positive total blood cultures. 3 were considered contaminants. And of the things that grew that were considered true pathogens out of those cultures, E. coli and Enterococcus are the most, or the only ones that were identified. And then the majority of these kids got treated for the sepsis, and then these many got treated for continuing culture-positive sepsis. This is the median antibiotic duration of 7 days, and then almost half got lumbar puncture done. The lumbar puncture, it's pros and cons. Pros, it gives you information, which is really useful. Cons, sometimes it doesn't give you information and confuses you more. So 2 of these kids had traumatic LPs, and so they were treated as presumptive meningitis out of that. And I don't know whether they had antibiotic exposure before the lumbar puncture or how the timing of that went, but either way, there's and then how did the babies who went to the NICU compare to those who were able to stay in the mother-baby unit? And again, these are the asymptomatic, not the ones who went straight out to the NICU. But how do they compare? Is there something that happened earlier in their course or that was in the baby's history that you could then say, oh, well, that provides evidence of that kid is higher risk of needing to go to the NICU, having an outcome that's concerning? This may be a little not easy to read from the cheap seats in the back. Dr. Casale, I apologize. And then here's our overlap. So birth weight, statistically similar. Gestational age, whether they're a girl or a boy. APGARs at 1 in 5 minutes. Maternal age, Hispanic race. This population was a largely Hispanic population, a little bit different from the Roanoke area. Cesarean rates, rupture of membranes, whether they were GBS positive. HCA is histologic chorioamnionitis, so in the kids for whom pathology of the placenta was sent, was there evidence of inflammation in the placenta? And then whether or not they received antibiotics prior to delivery. And really, out of all of this, and really this is a good thing, right? So if you're thinking like which kid is most likely to get sick, things like did they get a C-section? How high is mom's fever? All of that really makes sense as far as things that you want to look for in the data set. I'm getting into analysis. Forgive me if I've jumped categories. But the only thing that was truly statistically significant was the height of the maternal fever peripartum of 101.2 and 100.9. 0.3 of a difference is a little hard to make a lot of, come at with a lot of gusto, but either way, it was statistically significant, which is interesting. So what happened to the kids who ended up having to go to the NICU out of born, chorio, asymptomatic, go to NICU? So none of them died. So that's good, right? There were no significant morbidities that were found, and thus there were no morbidities associated with delay of antibiotics, right? Because there were no morbidities. Median duration of antibiotics, they got 7 days. Some of the other issues was that none of those infants were able to exclusively breastfeed, and the percentage that received any exposure to breast milk was lower in the NICU than those that remained on the mother-baby unit. So just to kind of click back through as we come into the discussion phase of the presentation. So the patients, babies born with chorio exposure, intervention of not using the antibiotic and seeing what happened to them. And then this is the retrospective evaluation of the outcomes, the primary ones being how many had to go to NICU, and then how many had a big problem that you actually needed to do something about. The sort of general critical analysis points of, are the patients all assembled at a common point in their disease? Yeah, birth, which other than conception is about as early as you can get in these things. So that makes sense, I think, as a common point to assemble the kids' chorioamnionitis when they're born. Was the follow-up long and complete enough to really answer the question that we're looking for? I think partly. So early onset sepsis in the immediate neonatal period with 48 hours of observation in labs, sure. Was there a kid that came back, though, at 72 hours? Not to this institution. And these were like 2 large children's hospitals in Los Angeles. But if they went to some other hospital and then got readmitted, we don't have that data to say for sure that these kids had no issues after birth. But it would seem reasonable, and I realize reasonable is not data, that if the kid was born at the hospital, mom had a problem, they would go back to the hospital. I don't know. And one of the thoughts I had too is that it wasn't a tremendous amount of kids in the study, right? It's like 200 and something kids. Like, they could have called some of the parents and seen. I guess it didn't happen. Were the outcome criteria objective or applied in a blind fashion? So it is objective in that lab criteria was one of the more common reasons that the antibiotics were given. The concept of ill appearing has some subjectivity to it. However, it uses objective data in order to say that, like respiratory distress, whether they're tachycardic, or there are factors that have a high degree of inter-operator reliability. Like if a kid has retractions, that has a pretty high degree of inter-operator reliability in measuring that. Like it's not a subtle thing, it's there. And you know, fever, tachycardia, things like that, you can measure all those as are objective. In a blind fashion, because the people involved in this study, it's retrospective, they didn't know they were being evaluated during it. So it's not like a double-blind prospective study. Although there is issues, of course, with studies are only good as the people doing them, and we all have issues of, you know, confirmation bias or whatever it may be. So the reviewers creating the study, do they have some sort of bias? I don't know. If there were subgroups with different prognostic categories, did they make, this is asking if they made statistical adjustment for kids, saying that, oh, you have something in your past, so we're going to say that we expect a rate of whatever to happen in the future. None of that happened. This was just outright observational, so we don't really have to worry about that aspect, if that makes sense. And also certain things like that you may think as being associated with it were found not to be associated with requiring NICU admission in this data set. Group B, strep, C-section requirement, things like that. And then how likely are these outcomes over time? So, and this is where I sort of wanted to kind of step back and look at the big picture. Like, what do you tell a mom who's got a fever and leukocytosis, right? Are you going to tell her, you know, pretending you're at UCLA, which we're not, is your kid going to need to go to the NICU? Half of them will, right? So even if it's a third went out of the asymptomatic, just total, half of them went. And because that other third was born and they had symptoms immediately. But if your kid is born and they look great, will they need to go to the NICU? About a third did. And that means about 5% of all asymptomatic kids were found to be truly septic. However, 2/3 did fine, stayed in mother-baby, went home after their labs, their observation, their negative cultures, and, you know, I assume went on to do great things with themselves. And then no instances of sepsis were missed and came back after discharge, at least that were identified out of the institution. So what are the big kind of takeaways from this study? I think that we were discussing that this article provides some evidence that it really may be a safe thing to take kids to hold off on antibiotics until they show you they have some symptom or lab abnormality that requires antibiotics and see how they do. The Canadians are doing it. That is nice. But studies come with limitations, right? So this is a small sample size, 300-odd kids, 240 that are in the asymptomatic category. And we're really worried about uncommon problems like death, significant morbidity, mortality. None were identified. It's hard to say for sure that this is a much safer practice unless you can say, I feel like we need a larger data set that lets us say for certain or with more certainty that this is a safe thing to do. You're not going to get kids who get tremendously sick when they go home. It just needs to be more people. And then this is more of an institutional, what do we do with that information in the Chorioamnionitis system? So let's say a baby's born to a mom, Chorioamnionitis at 10 p.m., and they're a patient of physicians to children or whatever. So no one's going to come in, no physician's going to evaluate that baby till 8 a.m. the next day. What do you do with that one, right? So we have wonderfully trained nurses and staff and all that, but I don't know, I feel like I'd want to have my eyes on the kid personally or have another practitioner with their eyes on the kid, and that's not the standard. So it's implementation thing, and as we have it here in our system, maybe this wouldn't be the best fit for all instances. Could we cajole the neonatologist to come and evaluate every one of these kids at 1 a.m.? I guess we could. Dr. Faye seems to be on that. And then we're also left with the kind of the big question of, are these babies going to other institutions after discharge? So I think the overall takeaway that we had from it was, it's an encouraging study, it's an interesting study, it provides some evidence to the idea of holding off on antibiotics, do less and see what they do. But I think a little more data is needed before we could feel truly very, very comfortable of completely implementing this. Dr. Whalen, sir, I think, I thought you were right here.
You can see what's coming. Somebody knew at this institution that they were doing things differently. Like, we already have this, whether it was written in stone, or we already have this policy or this written or otherwise policy of, we're going to just kind of treat these babies as individuals and do the lab workup on these kids and not automatically do antibiotics like the current recommendation. They knew before they started this study that our hospitals are treating these kids a little bit differently, so this is a prime place to look backwards and see how are we doing. Is this an official policy, or is this not recommended by the current American Academy policy hurting anyone? Am I incorrect in saying that?
No, that's right. This was the CDC policy.
Let's look back in time and see if we hurt anyone with our policy that we may or may not have written.
So another key point that I don't think they have talked about yet in this study, at these institutions, all babies with a diagnosis of chorio go right to the NICU because their newborn nursery cannot do IV antibiotics. So not every institution is set up like that.
That's not what they did with these kids in the past.
So in the past, I don't know for sure what they did.
Past,
yeah.
And they're telling us that 240 of these kids were exposed to chorio, and 100 and whatever, some went to the nursery.
2/3 went to nursery, 1/3 went to NICU out of that.
So why were they breaking with their own policy 6 years ago, 8 years ago?
How would we do this study?
No, they were going to do this.
The
start point and the.
As in, why is California doing something different from what AAP and CDC recommends?
No, I don't think it is like California, or if in general something that we are all doing on a settled way. If the kid doesn't have any signs of infection, and the baby is looking okay, first of all, I have to say something. The diagnosis of chorio is the first thing we have to discuss here, right? So the first thing you have to discuss here on the Canadian risk factor for sepsis, they talked about fever of 100 point something as the only factor for risk of sepsis. However, when we look at this study, they have fever plus 5 more things the mom needs to have, or uterine pain, other stuff to actually diagnose chorio. So the diagnosis of chorio depends. Where are you and why are you saying it's chorio, right? So that's one very important factor here.
So also, if you read the article itself, and if you go into the in-depth, so that definition gives you your N, right? That gives you the number that you're starting with at the very beginning of this study. It gives you your population. But in the body of the paper, they also described that was not always followed. So you had OBGYNs giving a diagnosis of chorio that did not really confine itself to what they decided would be their criteria. So already you're starting with an N that is slightly not what you've decided it would be. And so you have to, when you're evaluating these practices, you have to make sure that the population that you're looking at is the population that they're describing. So in some ways there was a little bit of a decrease in consistency about the population and the N that you would be looking at.
So one of the things that we're saying, I just want to go ahead and use this, so I start from the beginning. When we talked about the pyramid, the best evidence systematic reviews, well done, systematic reviews of randomized control trials hit everybody in the head, right? And that's not only for treatment, but for prognosis and for every question in general, right? Then you go to randomized control trials, hopefully blind and double blind and well randomized and well done studies with randomized control trials will actually beat core studies, and then core studies will be the end, but not just for therapeutic questions, but for many other questions. I just want to make that clear before we continue talking, because, you know, it's an important concept to have very clear. The other thing that I need to make clear is that this arrow sometimes makes you a little bit confused. Remember, in theory, the core study, you start with exposure, whatever it is, and you develop an outcome with time. Whereas retrospective depends whether the things already happened and you're looking at that in 2004 to 2008, or versus you are planning it now, and now knowing what I want, I'm defining what chorioamnionitis is. I am defining my case as well. I'm getting to collect all the information I do need, trying to get the best possibility to get all the information I need, and instead of digging on charts, trying to extract the information sometimes you are not going to find because nobody knows you care about what was my reason to admit this baby in the NICU when the baby was born from a deep febrile 102.8 mother. So the fact that it's a retrospective court makes it have information bias, not confirmation bias, information bias, like you are missing information, and the information you get is usually skewed somehow about whatever happened or whatever didn't happen, and you're not going to have the real thing, okay? So that's one of the things I just want to make sure I don't forget to say before we continue this discussion, okay? So you are right, Dr. Whalen. This is like many practitioners are not necessarily admitted in the ICU with antibiotics just because of the diagnosis of chorio. Starting because the diagnosis of chorio is so variable and not very well established. So knowing that, they went ahead and said, okay, let's take those asymptomatic chorio babies and see what happened to them when they didn't go directly to the NICU for IV antibiotics. So that's how the study started. They didn't know and they didn't think about, you know, anything before because this is a retrospective study, so they didn't really had anything in plan. They just wanted to see what the outcomes were. And then we have problems with definitions. We have problems with data. We have problems with numbers of patients that are going to make this article. No, we cannot make conclusions of this article, right? You have a question?
Kind of, yeah. So in the article they say, with the exception of fever, all the rest of the signs basically were documented in the minority of cases. Is it assumed that this is just a lack of documentation, or is it possible that they're just being admitted on the basis of fever alone?
So this is one of the reasons why I'm talking about information bias. We don't have that data, okay? So we don't know what the reasons were to admit these babies, but we know that 122 of them, which is almost something close to it, right, had symptoms at birth and needed admission right away, and the doctors follow the recommendations, or they have some sort of reason why they went to the NICU. What Matt was saying while he was talking about this is that we don't have documentation on but half of them of exactly why they went to the NICU. We might think it's because they were following the recommendations alone, or maybe they were symptomatic. Okay, we don't know. But from those asymptomatic babies who didn't go, 32% of them developed some sort of a symptom or bacteremia.
That's what I was thinking about the study, and you guys can correct me if I'm wrong, but I kind of understood the study as it's probably not a good idea to put every kid on antibiotics, and this is what we did. And like, this is what we did, but it's more of like, this is what we did. Every other hospital does things differently. Our kids turned out well. But like, I kind of expected the study to be like giving us guidelines of like, this is what's good. What they ended up saying is these kids went to the NICU, but they didn't really say this was the widest diagnostic criteria to send them to the NICU. They had like maternal fever, or like as know other studies do that, but this one is just like, this is what we did.
So it's like an observation, right? They're telling you what they have observed in their population. This was not a study that was designed to answer a question particularly. What they're saying is, this is our population, this is what we did during this period of time, this is what happened with our patients. But you're right, in most cases when you're doing a clinical trial to try to answer a clinical question, they will say at the end whether what they did was appropriate or not appropriate, and give you an odds ratio or a hazard ratio of using these clinical criteria to actually manage this clinical situation. But that's not what this study is. This really is an observation, a retrospective review of what their population looked like if they applied what they tell you are their definitions here. I think one of the things when you were talking about whether they were readmitted or not is actually very appropriate, because they say they had no morbidities, zero morbidities in these patients, but they don't describe what morbidities they considered a morbidity. Okay, they didn't describe what it would be. It's very unusual to have babies who go in for sepsis or near sepsis and not have any morbidity whatsoever. And so no morbidities, nobody died. But what happens to babies who went home and were either readmitted at another institution, which could be likely, very likely in LA, or died at home? You don't know what the follow-up is for this population truly. Or did they go to see their respective pediatricians and have a morbidity a week later? So we
had some ototoxicity.
Exactly. So we
that we just called a thing that's going to happen.
Yeah.
You didn't pass your hearing screen.
So I think there's a lot of data missing to be able to say with any kind of good criteria, this study shows us that we should be doing this. This is a part of information that you can use in clinical activity, but it is not a guideline.
Mm-hmm. And that's very important because a lot of people might argue, and I don't know if any of the attendees who are here will argue, this is a high-risk population. How much of a risk are we getting when we decide not to intervene, right? We have that at least 65% of them become symptomatic of bacteremia actually on the blood test, which is not easy to get. It's hard to get bacteria growing in your blood in one blood culture we get from them at birth. Many times we don't get it, So many of them were symptomatic, right? So are we safe enough ignoring that 55% of these kids actually need some sort of NICU admission and IV antibiotics, maybe for symptoms, maybe for not, but we don't have that data very clear. And I just want to say that because there's a lot of young people around here who hasn't been around enough, and I don't want you to take it easy when you hear the mom has chorioamnionitis, because as you see, if you see it on the other side, they argue we might be treating too much, but you can argue the other way around. Many of them ended up in the NICU, and many of them actually were symptomatic. At least we have data of 0.5% of them that went to the NICU had some sort of symptoms, and then you have data from the ones who didn't go to the NICU. Those 78% of the babies who ended up in the NICU, 59 of them were asymptomatic, but then 19 were symptomatic. So you have a big percentage, and what you're talking about here is sepsis, which can drive to death. So I just want to make that clear for you guys, especially for the young people and medical students, so you don't take it easy. If you hear a mom having chorioamnionitis, you actually think about, oh my God, how could I end in the NICU? There might be some sort of thing, some sort of intervention.
So I just have some questions about the criteria that they're using to diagnose a sepsis. Because, I'm familiar with the sepsis bundle in the adult world, but I'm not sure how that crosses over to pediatric. I'm just wondering, bacteremia doesn't necessarily equal sepsis. How you can have an asymptomatic septic patient because maybe bacteremia.
So in this, I believe they defined it as culture documented bacteremia. And in the adult world, there's like the SIRS criteria, which is a whole kind of different, In the adult world, there's the SIRS criteria, which carries a lot of prognostic value in the adult patients of leukocytosis, fever, there's a few other things that I've subsequently forgotten because I don't have to use the question. in this, that's what they used, was presence of bacteremia as the nugget of it.
I'm just wondering, I mean, people are bacteremic every day, and it's not necessarily everybody going into sepsis, but I didn't know if that was different to newborns, obviously.
Right. Well, that's an interesting theoretical.
I would say that if a newborn grew a pathogen, grew a gram-negative enteric or enterococcus,
it matters.
They can't.
Yeah.
That's a pathogen, and they're at risk of death, and they can't fight it. So I think it's a pretty safe definition to say that a true pathogen in the blood coming to unite is sepsis, and that's reasonable. I want to try to summarize this. So if I look backwards over the past 10 years at what my colleagues did, not knowing what criteria they used to diagnose chorio and not knowing what protocols they used, if I just look back with my current definition of chorio and pull all the charts and review what happened to those kids and identify a population who didn't immediately go to NICU, it looks like I didn't kill any of them. Right.
Unless they died somewhere else.
Right.
Unless they died.
I was talking about families. There's more than 2.
Yeah, there are more than 2. A lot more than 2.
Matt, I've got 250 Hispanic families that had babies born in the last 10 years. Could you call them all and see how those babies did?
Oh, por supuesto.
Well, if we just, it will be maybe a lot of work to do that, but at least you could try now. If you try to call your patients to give them results, and you tell me you get them all of them in the first try, please let me know what you do, because it's usually more than that. However,
on an undergrad, I feel like you do it over
sure, give them college credit.
Over a week or two. 200 people, like I used to do calls for research trial. You could knock that out in a couple of days if you were motivated.
Good luck finding their numbers.
And I'll be happy to. I want to hire you, Matt. Yeah, absolutely.
I mean, tell some other, telemarketers, insurance already.
one other thing I want to say just before we continue is that even though we said no, this is an observational study, so we are not intervening. We don't have an intervention here. We're just saying, we try to describe what happened just exactly like Dr. Whalen was saying. I just want to say, remember, all of them got CBCs, blood cultures, CRP, observations, and they not only get it once. They get it once, 6 hours, 12 hours, 24 hours. So that doesn't mean nothing, right? So just, again, coming back to this is a high-risk population, okay? Anybody has any other questions? Anybody in line having any other questions or comments? You have, how do I mute it? Do you know how I unmute it?
Yeah, I think he's the red one.
It's unmuted.
Oh.
Is anybody in line having any questions? All right.
Thanks. Thank you.